You're listening to Speaking Sidemount, the podcast where we talk all things sidemount diving, from equipment, skills, techniques, and sidemount diving expeditions to interviews with some of the world's top sidemount divers. Whether you're new to sidemount, been sidemount diving for years, or just want to know more, this is the place for all things sidemount. I'm your host, Steve Davis. Let's get wet.
Hey, welcome back to Speaking Sidemount. I'm Steve Davis. This episode is brought to you with the support of our sponsor XDEEP and the patrons of Speaking Sidemount. My huge thanks to both. Your very kind support makes everything you're about to listen to possible. And in the second part of this series with Professor Simon Mitchell, we're going to talk about the influence of gas density and CO2 retention and how this may very well contribute to some of the more well-known dive accidents that we've experienced. I asked Simon about the relationship between CO2 and panic and share my thoughts on the relationship between the psychological aspects of an issue in the water and the physiological responses that our bodies have to these stresses. And then Simon gives us some advice for divers in a panic situation and also for rebreather divers faced with a CO2 issue. We then hit on some misconceptions or poorly understood areas, such as reverse profiles, the issues with multiple deco dives in one day, and we talk NDL for recreational divers, discuss what it really means before we chat about free diving after a scuba dive. We finish off with Simon sharing his extensive experience on applying human factors in diving. All this and much, much more in this episode of Speaking Sidemount.
Another one that comes to mind that I've been thinking about a lot lately is gas density, and you can educate me and our audience on how that might apply to decompression, but certainly it does apply to other aspects of diving, worker breathing in particular, and CO2 retention, hypercapnia for rebreather divers in particular, again, is a very important thing to keep an eye on if you can. And so let's talk about gas density for a little bit as it pertains to diving deeper in particular.
Yeah, look, I became interested in this back in the early 2000s when David Shaw had his fatal accident in that cave in South Africa. And as you know, he kind of videoed his own death. It was very sad. So, he was diving to about 264 meters, I think, trying to recover a body of a diver that he had found on an earlier dive. So he successfully dived to that depth before. The difference between that first dive and the one where he died was a small amount of extra work. And, that video was shared with me, and David's family very generously allowed us to make commentary on it and publicize that commentary, which to their credit has actually spawned a whole new age of awareness of gas density issues in the subsequent decade or so. So they should feel very positive about that. I mean, if it is possible to feel positive after a thing like that. But anyway, what that video showed was that as the dive progressed, David's breathing became increasingly labored and developed characteristics of respiratory distress that had previously been published in experiments with high density gas, but in humans in hyperbaric chambers. And it led us to the conclusion that he died because he got to a point where the gas was so dense that it limited the amount of breathing he could actually do to get rid of carbon dioxide. And look, this is an important point to make, and I need to introduce this here, that when we consume oxygen, we produce carbon dioxide. Carbon dioxide is actually a toxic gas to us. We have it in us all the time, but we keep it at a very controlled level. And we get rid of it by breathing. And if you don't breathe enough, the CO2 levels will go up and up and up. Now, for you and I sitting here at atmospheric pressure, it's no difficulty breathing enough to get rid of the carbon dioxide we need to get rid of. But when you're down deep, breathing very dense gas, it can get to a point where you actually can't breathe enough to get rid of the carbon dioxide you're producing. And when that happens, the carbon dioxide level rises and your body goes, oh, we need to breathe more to get rid of carbon dioxide. And so your brain drives you to breathe harder. And all that does is produce more carbon dioxide because the gas flow is limited by the density of the gas. So you can't breathe more, but you try harder. And you get into this downward spiral of producing more CO2 and not being able to get rid of it. And we're virtually convinced that that's we are convinced that that's what happened to David. So that led us to get very interested in this whole gas density thing, like how dense can your gas be? And in the aftermath of David's accident, I went looking for that answer and really struggled to find anything objective. Like no one had really done the work. There were one or two speculative guidelines, but no definitive data. And actually, I'll tell you, Steve, it's one of the very cool things about diving medicine is that there's still so many low-hanging fruit in this field, questions that in any other field of medicine would have been answered 50 years ago, but they haven't been in diving medicine because there's not the money or the people doing the research or whatever. And this was a classic example. And then it must have been about, I forget, it was Eurotech 2016 maybe, or maybe slightly earlier than that, 15, I can't remember. But Gavin Anthony, who's a scientist, works for a UK underwater breathing apparatus testing house called Kinetic. He turned up at Eurotech. He's an amazing guy, Gavin. I've known him for years and just retired, actually. Very clever, but very understated. He does all this amazing work. You hardly ever hear of him. He turned up with this gas density data, which, I won't describe in any detail, except to say that he identified a gas density of about 6 grams per litre as a point where there was a significant inflection in the risk or increase in the risk of not breathing enough to get rid of all the CO2 you're producing if you had gas denser than that. And that was in underwater tests of rebreathers in a controlled environment with working divers where they were actually measuring the CO2 in the divers' bodies. That was an amazing piece of work. The numbers he had, there was 600 or 700 dives in this database. It was convincing data. And I said to Gavin at the time, I said, look, mate, when are you going to publish that? And he was a bit like, it was typical Gavin, he, like I say, amazing, brilliant guy, but somewhat understated. And he didn't have any concrete plans to publish it. And I said, well, look, okay, how about I write the paper? You can be the first author, but it's your data, like it'll come out under your name, but we have to get this into the community. So we published it. And that has now got quite a lot of traction and a lot of people are focusing on it. And rightly so, I believe. Now, it turns out that 6 grams per litre is about air at 40 meters. So that means that the PADI kind of recommended limit of air no deeper than 40 meters is probably about right. Yeah, but an important perspective is that if you dive with gas denser than 6 grams per litre, it does not mean that you are going to have problems. It just means that there is an increase in the risk of having problems. And so the 6 grams per litre thing represents an ideal limit, but not one that one would necessarily have to stick to in every single setting. Because I'm often quoted now, one of the things that happens with divers, right, is that they'll take a concept and extend it beyond the point that you intended it to be extended beyond. So, deep stops, classic example. Simon Mitchell says you should not ever do deep stops. I haven't said that. I've just said the deepest stop shouldn't be too deep. And now they're saying, Simon Mitchell says, if you dive with gas denser than 6 grams per litre, you're going to die. And I'm not saying that. I'm just saying the 6 gram per litre thing is an indicative marker of increased risk. And so it is an ideal limit. And if you can stick to it without there being too many other logistical issues, then that's great. If you can't, then you need to take account of other potential risk mitigating strategies, like, for example, avoiding hard work. On the Pierce expedition last year, Harry and Craig dived 245 meters, and their gas was denser than 6 grams per litre. I think it was in the 7s or something like that. I forget exactly what it was, but they were well aware of the issue and basically took steps to avoid doing any work. That's the key thing. The worst combination is combining dense gas with hard work. And especially if you do it with underwater breathing apparatus that has a high work of breathing of its own. So like the high breathing resistance. And rebreathers are actually bad for that. Some worse than others. But if you're going to use a gas that's denser than 6 grams per litre, then you want to not do any work and you want to have other sources of breathing resistance like your rebreather as low resistance as possible. So there are ways around it. It's not a 100%, if you do 6 grams per litre or more, you're going to be in trouble. It's just an inflection in risk that people should be aware of.
Yeah, clearly this drives you towards trimix and starting to introduce helium into your mixes. And the reason that I've been thinking about it is there's something that nobody really speaks about. We talk about work of breathing with our rebreather, and we talk about gas density and trying to minimize work. And you've heard me talk about it too, and I feel like I'm a broken record, and that is the impact of streamlining. In fact, whether you're using a scooter or whether you're swimming, but in particular, if you're swimming at depth, the more streamlined you are, the less drag that you are producing, therefore the less work required to propel you through the water. And my criticism of many technical divers is that they pay no regard, I'll call it scant regard, to streamlining, and therefore they're kind of like a brick trying to move through the water, and they overcome it with a scooter, which is fine until you have to swim. One thing I'd love to see some research, and it's done with swimming a lot. Olympic swimmers pay immense attention to this. In fact, almost as much attention to how streamlined can I be as how fit can I be. It's that important when you're in the water. Probably it's not a medical field. It might even be an engineering sort of fluid dynamics type field, but doing some work on work of breathing versus streamlining and seeing for a given work of breathing or for a given gas density, what impact does it have if we become more streamlined? I remember in the 70s, Jacques Cousteau had all these amazing streamlined outfits. Not that they were particularly diving well back then in our parlance, but they did, didn't they? I mean, they wore streamlined helmets. They streamlined their twin sets. They wore what looked like very slippery wetsuits. What are your thoughts on that?
Look, I have little doubt that you're right. It's just a field or an aspect of the field that, as you correctly point out, has almost been ignored, other than in a theoretical sense by people like yourself, instructors who say, well, look, being streamlined is going to decrease work. But that is the point, that streamlining addresses that work side of the equation. Whatever your gas density is, the less work you do, the better. But particularly if your gas density is high, the less work you do, the better. Streamlining has the potential to decrease your work. There's no question about that. But I can't put any numbers around it or attribute any, objective significance to it, because as far as I can tell, absence of any relevant data. The problem with it is, Steve, it actually would be quite a hard thing to study. You probably need to do it in a swimming pool. Most of the exercise studies in pools have been done with static divers on exercise bikes, and that's quite easy to do. Whereas streamlining by definition means you'd have to be studying a moving diver with all the monitoring that you need in place.
Well, or you do it in the swim flumes, the ones that have the water flowing through. I think that's what they do with swimmers, and they're looking at a lot of the fluid dynamics, a little bit like a wind tunnel with water, of course.
I only know of a couple of places in the world where they have those in a diving research. They have one of those at the Karlskrona unit in Sweden, where I was doing a bit of collaborative work. It's a very cool device. Yeah, you could do it in a situation like that and change angle of attack and change the way
exactly, and the equipment configurations. And it's something obviously that's very dear to my heart in terms of the way that I think people should dive and the way they should configure their equipment. And I don't feel that those of us who speak about this get a lot of breakthrough in terms of the way people especially manage their cylinders. It's a hot subject with me, but clearly there's other factors in there as well. It's just something that always comes to mind when I'm thinking about the amount of work that I need to deliver in my diving. And then the deeper you go, the importance of being still. And of course, I was aware of Harry and Craig in their dive and how they were focused on being still and relaxed. And as I hark back to Dave Shaw, I'm sure that was Dave's intention as well, until he actually had to do some work. It wasn't so much that he didn't want to be relaxed. It was more the fact of the act of getting the body into the bag and then dealing with lines and so on resulted in a necessity for him to do more work than he wanted to. And of course, I watched Into Darkness again last night, the cave diving incident in Plura in Norway. And again, I'm surmising that the divers who perished in that accident, they got themselves jammed in a space. And I'm pretty certain a cascade of work of breathing, becoming anxious and over breathing CO2, and then everything cascades out of control from that point. I'm sure there's many other accidents than Dave Shaw that we could absolutely attribute this factor to.
Oh, no, I suspect you're right. You described it really well. I mean, that cascading series of things, your CO2 doesn't have to go up by much before it too will start to contribute to anxiety, confusion, panic. So as you say, once you throw that into the mix, situations can get out of control very fast.
Maybe you can correct me. I'd say this a lot, and I don't know whether this is based in fact or not. So let's ask this question. So often when I refer to panic, it's a psychological response. And in my mind, it's a psychological response often to a physical stressor. And so there's some sort of physical thing going on and you're diving, you're entrapped. In fact, that happened to me, right? So you get stuck somewhere, you're stuck in a restriction, you're stuck in a shipwreck, or something else is going wrong for you. First, you have a psychological response, something's going wrong. That results in a physiological response. I increase my rate of breathing. I start to work against whatever I think is causing the problem. I start to build CO2. CO2 has a physiological and psychological effect on me. And I'm trying to, I guess, paint a path towards panic. And what contribution does CO2 make to that state of mind, which we refer to as panic?
Actually, you summarized it pretty well. I mean, clearly you can have panic without any influence of carbon dioxide, but carbon dioxide will definitely enhance the chances of a panic situation arising because, as you correctly point out, it has both psychological and physiological effects. So if your CO2 goes up, it makes you short of breath. It'll increase your pulse rate. And so those are things that are often part of the panic response, even if the panic's coming from somewhere else. But also CO2 gives you a feeling of impending doom and extreme discomfort, shortness of breath, which is a terrible sensation, like feeling like you're suffocating, which you're not because you're breathing in and out okay. It's not like you can't breathe. It's just that your body's telling you that your breathing is inadequate, which increases your breathing rate, contributes to this feeling of shortness of breath, and you get this psychological feeling of impending doom. And like it's an absolute recipe for panic. And if you throw that into some environmental stressors like being stuck and being fearful for your life from that perspective, it's just going to multiply everything simultaneously. So yeah, no, you're exactly right.
Well, let's give some advice to divers then. There is a chance in your diving that you're going to experience this feeling. I mean, we refer to it quite often as a CO2 hit. Let's say you get yourself in a situation where you're overbreathing, you start to feel some of these feelings, you start to feel panic. The general advice is stop, take some deep breaths, think, is that the right way to go? I mean, what advice would you give to someone in that situation?
No, look, I think, the classic PADI open water course advice is actually pretty good. There's some contextual things to it, of course. There's more than one cause of carbon dioxide toxicity. So it could be that you're just not breathing enough. But if you're on a rebreather, it could be because of scrubber failure as well. And so, on a rebreather, stopping, resting, taking deep breaths, but also bailing out is probably the right thing to do, unless you can be absolutely certain it's not your scrubber. And the only way you can be certain of that is if you've got a carbon dioxide monitor on the inhale limb of the circuit that you're confident in. But most rebreathers don't have that. So bailing out in a CO2 hit situation is maybe the way of resolving it. Yeah. But yeah, I mean, your advice is right. What you don't want to do is panic, work harder, and take very rapid, short, shallow breaths, because with shallow breathing, a much larger proportion of each breath that you take is going to be dead space gas that's got CO2 in it. At the end of an exhalation, you've got about 150, 200 mils of gas in your airways that is exhaled gas. And that's going to be the first gas you re-inhale when you take another breath. And of course, then if you bolt on a mouthpiece, and some rebreather mouthpieces have another 80 to 100 mils of gas in them. If you've got, say, a total of 250, 300 mils of dead space and you're only taking 500 mil breaths, then each breath has got very little fresh gas in it and you're re-inhaling a lot of CO2. That's why the advice is to take biggish breaths when you feel like you're in that situation.
Well, thanks. Let's move on to a couple of other areas. So we've covered temperature change, we've covered gas density. Let's talk about some misconceptions for a moment. You and I spoke about some other areas that we could look at. And one that comes to mind a lot, virtually every dive boat, every dive center, every dive agency you talk to talks about the evils of reverse profile. So you should do your deepest dive first and your second dive should be a shallower dive. Is there any real science or evidence to support that?
No, not really. It kind of goes back to the old days where if you were using tables and you had two dives, one deeper than the other, and you computed them in both orders, deepest first or shallowest first, the tables would give you a different resolution for the two dives. So, and in particular, if you did your deepest dive second, the table would want you to do more decompression after that dive than it would have after the same dive if you did it first. You'd expect that. But that kind of led to the perception that doing the dives in reverse order was bad from a risk point of view, but there was never any actual data that suggested that that were true. Like there were no studies that actually showed that. But it did lead to this idea, this kind of dogma, deepest dive first is always better. Now, actually, it probably does make sense to do your deepest dive first. I'm not saying it's a stupid idea, but what is stupid is if you've done a shallow dive and then you're prevented from doing a deeper dive afterwards just because it's deeper than the first dive you did. You know, if you're prepared to do the extra decompression that's required by the deeper dive, taking account of the first dive that you did, I don't see that there's any problem with it. This dogma led to some really stupid behavior by divers. You know, when I was in Australia, in Brisbane in particular, they were quite hot on it on the Barrier Reef. And workplace health and safety were all over any diving incidents that occurred over there. And so if you had a bunch of divers on a liveaboard dive boat, so the advice was on your first dive of the day, at some point you wanted to spike down to some, you know, like depth greater than any other depth that you might want to dive to on that day, just so that no one could ever say that you did a deeper dive after a shallower dive. Like what a stupid idea that is, spiking down. You know, you're doing a dive on a 20-meter wall with a bit of a drop off. So, oh, well, look, just in case we want to go deeper than 20 meters later in the day, we'll quickly zip down to 40 meters and back up, just so that it's on our depth gauge and no one can accuse us of reverse profile diving. How ridiculous. So that sort of behavior was going on. And it wasn't just on the Barrier Reef, that's where I was. And so I saw it, but it was occurring all around the world. And so I forget which year it was, but Michael Lang and another guy, they were working at the Smithsonian Institute, so big marine biology, you know, massive organization, but with a marine biology component. They had a scientific dive team. They wanted to sort this out because it was creating issues for them. And they ran a workshop where they pulled decompression experts from all over the world. And basically the conclusion they came to was that there was no problem with doing reverse profile dives. There was still a bit of controversy about it, but they specified a reverse profile gradient for recreational dives of 12 meters. So in other words, if you did a 20-meter dive first, you could do a 32-meter dive second, and that was okay. Obviously, that doesn't apply to technical diving. I think with technical diving, you do need to be careful, not because of the reverse profiles, just because you don't want to do too much diving in one day. Generally, if I do a 60 or 70 meter dive, that's it for the day. You know,
absolutely.
I don't generally do another dive.
I think I've related this to you before when we were talking about Truck Lagoon. Gozo, Tom Steiner's famous saying was, one deco dive a day keeps the doctor away. I've related this before, despite the fact that I was making €18 a dive. There was no way I was allowed to do a second dive, having done a trimix dive in particular. We're not talking about small decompression dives where you might have gone to 35 meters and your gradient factors are such that you've incurred maybe 10 minutes of deco. We're talking about the 45 plus 50, 60 meters where you do one of those. Do you want to go and do another one? And I know you go as the hyperbaric physician on Pete Mesley's trips to Truck, which are just phenomenal, by the way. I'm still dying that we haven't been for 2 years now because of COVID, but we did the workup dives. But as soon as we got to San Francisco Maru and started doing the 50-meter plus dives, that was it for me. It was one a day. I dived every day. Pete usually says take a day off, but once I was on that, I was comfortable. And again, do your deco, pad out your last stops, which we did a lot. But yeah, this idea of doing more than one of them a day, I think is not a good idea.
Yeah. I mean, I guess the point I'm trying to make, Steve, is when saying that I don't think that there's a particular problem with doing reverse profile dives, what I don't want is people saying, oh, well, Simon Mitchell said it was okay to do a 70-meter dive, then a 90-meter dive, you know, like in the same day. Because I'm not saying that. I'm just saying that, like, when it comes to deep technical dives, I think one big decompression dive a day.
Yeah, I think we're very much in the recreational space here, and it's being driven not so much by the tech diving community, but more by when you happen to cross paths with the recreational community. I mean, there is a practical factor from their point of view. I experienced it the other day where We dived Canterbury, we're at 30 odd meters for much of that dive, and then they're diving air. So when you come to do your second dive, it really just isn't feasible to do a deeper than 30. You don't even want to, or even to go back to Canterbury, because their dive time, their NDL limits become 15, 20 minutes. Yeah. And that's another thing that comes up with me, especially in the recreational field, is this dogma around NDL. There's a line in the sand, you're going to die if you go over it, or there's an NDL line. If you go over and go into deco, you are in such trouble. And I'm not saying you should breach limits, by the way, but all I'm saying is that this idea that NDL is some sort of God-given line and it means a lot is really not correct, is it?
No, of course it's not. Well, for a start, even forgetting about doing any appropriate decompression if you exceed an NDL, it's important to understand an NDL is just someone's version of a line in the sand on appropriate risk. Like, it doesn't mean that if you exceed it and don't do any decompression, you're going to get sick. And it also doesn't mean that if you stay within it and surface normally, you're not going to get decompression sickness, because sometimes people do. It's just a line in the sand of acceptable risk. And some people will conform to that level of risk, and some will exceed it, and some will be less than it. But the idea that it's some kind of disaster if you exceed an NDL and have to do a few decompression stops. Well, the trouble with it is, Steve, that as tech divers and people used to doing decompression, we're very happy with that concept. And I think, if someone like Drew Richardson was in on this call, CEO of PADI, he'd probably say, look, our chief concern is it's not that we think that there's a big danger associated with it. We're trying to impart a sense of this is your limit on people who are not trained appropriately to plan and execute decompression stops. And I think that that's probably a fair perspective. That's their main concern with it. Unfortunately, in teaching that, it comes across, as you point out, that the NDL is this kind of magical boundary where if you exceed it, all hell's going to break loose, which of course is not true.
Yeah. One other thing that has been somewhat interesting to me, even though I don't do a lot of freediving, is the impact of freediving and DCS. And I did hear a story of, was it William Trubridge having a decompression incident after doing repetitive freedives? But he's at the world leading competitive end of the spectrum. But more for the rest of us is there any type of real risk to freedivers in doing repetitive freedives, firstly? And then secondly, is there a risk, logically I think there is, of freediving after scuba diving?
Both of them are under-researched areas. What I can tell you is unequivocally there are a number of case reports of extreme freedivers suffering symptoms that appear to be consistent with decompression sickness. And I can't speak for William. I'm not aware of that issue with him, but I am aware of several case reports of freedivers, like I say, developing symptoms that seem to be related to decompression sickness. And in theory, it's possible. However, to be in that zone, you have to be, like him. And there's not many people who are doing that kind of stuff. And if you look at the history of, say, spearfishing competitions in New Zealand, where you've got guys swimming in the water for 6 hours, up and down between the surface and 20 to 30 meters frequently over that period of time. We've never seen it here. So it's only these people that are doing the super extreme free dives. And I just don't think it needs to be a consideration for your average spearfisherman or even your above average spearfisherman. It's just not going to happen. However, the other scenario you talk about is free diving after scuba diving. Now, that too is controversial. The concern there is that if you have a bunch of small bubbles, you remember we talked earlier about PFO and its significance and how it allows bubbles to get across into the arterial circulation that would otherwise be trapped by the lungs. There's some concern that intermittent spikes in pressure can actually promote redistribution of bubbles through the pulmonary circulation. Now, to my knowledge, that's never actually been proven. But again, there've been a couple of case reports of scuba divers who have ended up with decompression sickness after free diving, immediately after their scuba dives. Now, whether that actually arose because of the phenomenon that we're talking about, so bubbles trapped in the lungs getting compressed and getting through the lung circulation, or whether it was just going to happen anyway, nobody really knows. And there's never been any systematic research done on it. My advice is that if you've been doing anything like serious scuba diving, and look, I don't know how to put a threshold around it, but if it walks like a duck and quacks like a duck, Certainly if you've been doing decompression diving or anything close to NDLs, free diving in the aftermath, especially the first couple of hours after a scuba dive, where we know that the sort of venous bubbling peaks around that time and then falls away. I think that's probably not wise, but I can't put any definitive answer on it. Yep. Steve, if you're out at the Poor Nights doing a typical day of recreational diving and you're in your surface interval between two dives, I'd probably avoid it. You know, you could swim around on the surface and float about and have a look, but I think diving up and down, it's an unproven concern, but it is a concern, so I'd probably avoid it.
Okay, we've got it there then. Let's close off with one last point that I wanted to raise with you. I did a really good interview with Gareth Locke, I think it was episode 38, 39, where we talked about human factors. And as I'm sure you're aware, Gareth has taken the human factors, call it discipline, that he learned in the Air Force with aviation and has applied it to scuba diving with a lot of success, I think. And I know you've had a really solid look at this yourself with respect to rebreather diving in particular. Can you share your thoughts a little around human factors and how it pertains to, in particular, rebreather diving?
Yeah, look, if you look at the rebreather accidents that have occurred, and there's been many of them, fatalities, where we actually have some information and we know what happened, there's a huge proportion of them that have arisen because of relatively simple errors. Oxygen not turned on, or rebreather not turned on when they jump in the water, or dry suit not connected, or the diluent cylinder not turned on or half empty, and these are all things that could be avoided relatively simply. And I have a huge interest in human factors, not so much in the diving area, but in my parent area of anesthesiology. So we've done quite a lot of research on the use of checklists in the operating room. And it's germane to point out to your audience that it's 12 years ago now, we were involved in a big multi-center study all over the world. It became very famous, known as the WHO study, or the World Health Organization Surgical Safety Checklist study, where basically we assessed the impact of introducing a relatively simple checklist into operating room practice in places where they hadn't had one. And, the checklist had on, is this the right patient? What operation are they having? Have they had antibiotics given at the right time? Do they have any allergies to medications? What specimens are we sending to the lab? Have they been labeled correctly? So there's a bunch of things that happen in the operating room on this checklist, right? These are in places where the patients would have turned up and expected they were going to be looked after by highly trained professionals, very unlikely to make errors, which is all true, actually. But, we're humans, right? So humans make errors. There are omissions and errors that occur. The introduction of this checklist caused a reduction in mortality, so deaths out to 90 days after the operation, by about 50%.
Wow.
And a reduction in a predefined set of complications, like did the patient get pneumonia? Did they have to have a blood transfusion? Did they blah, 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 by about 30%. Now, that result was considered to be so good that it couldn't be true. It must have been some kind of aberration in the numbers. And then subsequently, there's been 3 or 4 attempts to repeat the study, and basically they've all shown the same thing. It's an absolutely stunning result. It hasn't been ignored. It's been widely reported and it has become quite famous. But I can tell you now that if that was a new drug or a new operation, it would have been hailed as the greatest advance in medical care, in this last century. But because it's kind of human factors and it's perhaps not quite so sexy, then it hasn't gained the prominence that it deserved. Anyway, the point about this is that it speaks to the power, the potential efficacy of simple, costless, easy interventions on preventing these kind of errors. And I put it to you, Steve, that if every rebreather dive since we started using rebreathers had begun with a very simple checklist with 4 points on it. Is your oxygen on? Is your rebreather turned on? Is your DIL on? Is your dry suit connected? If every rebreather dive had started with a check and response, with the dive master or whatever, or just between buddies of those 4 things, we'd have about half the number of rebreather deaths that we currently have had. Yes. Very, very simple, very effective. So human factors, again, I make the point, we've spent all this time debating deep stops. Decompression sickness hardly kills anyone. Don't get me wrong, I'm not dismissing it, but it really, in the big scheme of things, it's actually a minor issue. Whereas jumping into the water with your rebreather not turned on is a major issue. And there are actually quite simple ways that we know from cross-fertilization by research in other areas like medicine that it absolutely works. I mean, look at pilots. What we need is a culture similar to the one they have, where if the first officer came onto the flight deck of an A380 and said, oh, let's not bother with the friggin' checklist today, I mean, they'd be fired on the spot.
Yes.
It's part of what they do. It's part of who they are. And that's where we need to get to. We need to get to a point where people are saying, look, using the checklist is not a sign of weakness. It's not a sign of stupidity. It's a sign that we're actually good divers. And this is part of the deal. You know, we just do it. We don't even think about it.
Yeah.
That's where we need to get to. And Gareth's trying to drag the diving world to that point. But, you know, it's an uphill battle because confronting people with their own fallibility is sometimes a bit hard for them to swallow. I mean, we had this issue with the surgical safety checklist. Like surgeons don't like to be told this. But they actually, for various reasons, and I won't get into it, they've embraced it because they're actually very smart people and they've figured out that it really does work. And, you know, now it is becoming part of our operating room culture. We need to get to that point with divers.
Yeah, and I think certainly in New Zealand and in the groups that we, or certainly I move in, that is the case now. We can't get off the boat without having the dive operator check us, as well as running through your own checklist. It sort of brings me back to my discussions with Gareth, because one thing I criticized him of a little bit is overcomplicating this, not to take away or to denigrate the field, because we was doing a PhD on it. So I understand that there's a lot of complexity there. But when you make things too complex, again, you know, back to what I was complimenting you on, we need to simplify this so that it becomes digestible and usable by divers who are doing this generally not for their employment, but for their pleasure. And so coming back with, as you pointed out, a small checklist that has a short number of things that are going to be the things that are going to cause you large problems, if not a fatal accident, if you don't have this right, is the way to go. And then I think in terms of explaining it to people so that they understand why they should do this, we have to understand how easy it is for us to become distracted, in particular by things that are going on around us or other things in our life, which then cause our minds to go off in the wrong directions. And it's generally a lack of focus on the particular task at hand that's causing the problem. I'm concerned that I'm the last one in the water. I'm being rushed. I don't feel as if I'm ready for this dive. I don't feel as if we briefed well enough. So there's all these things going through in the back of my mind. Maybe it's a push dive for me. I'm starting to extend my comfort zone by doing something I haven't done before. So therefore, all of those factors are playing in the back of my mind. And while I'm trying to use something as complex as a rebreather at the same time, it's pretty easy to miss something in that scenario. Of course, if we're all sitting there completely lucid and relaxed and not distracted, then it's pretty simple not to miss it. In my mind, that's what's going on a lot with human factors. We're just so susceptible to distraction and complacency that we miss things.
Yeah, and that last stanza of commentary from you, that whole block of commentary that you just made is absolutely spot on, prescient. It's exactly the message. And I do take your point about overcomplicating it. What Gareth likes to do is to explain the theory behind the practicality. And that's a difficult line to walk because some divers are receptive to that and like to understand the human factors theory and concepts underpinning the recommendations, but others just want some simple recommendations. And that's the line I'm tending to take. By the way, I completely agree with you. Gareth is doing a fabulous job, and he, more than anyone else, has brought this issue to the fore in diving and deserves all the kudos for that. But I do agree with you that we need to try and keep that message quite simple. And in particular, your point you made about the checklists, you know, I was implying it by giving my examples, but you've encapsulated this piece of important information that we need to keep them short. People need to understand what a proper checklist is. Like the pre-takeoff checklist on an A380, I've been in the cockpit. I'm friendly with these guys because we learn from them. I've seen it, got a photograph of it. It's only got about 6 or 7 items. That's it. Taking off in an A380 is quite a complex procedure, but they don't have a manual. They just have 5, 6, 7 killer items that will destroy the plane if you don't do them. That's what the point you made, and it's so right. And that's why I say we don't want these complicated, you know, long checklists. We just want to choose a very small number of things that will completely ruin your life if you don't do them. And that's what should be on your checklist. You see these people say, oh, yeah, I use a checklist, and they pull out a couple of pages. It's like, you know, the build instructions in their manual for their rebreather. That's not a checklist. I could go on for ages about it, but I think you get the point, and you've said exactly the same thing.
For the Sidewinder, I do have quite a long build checklist. So I'm going to say that's one A4 page. And I don't know how many items, but it is the manual. Here's how you build it. And I do check each item off, and I am pushing myself not to do it from memory because I can now. Yeah, because I can do that now. I'm a bit over 100 hours in now. And so I'm really pushing myself to keep checking the checklist and sign that. But my on the boat checklist, my before in the water checklist, I think I've got 6 items on that. And some of them are driven by the like dumb things that I've done as well. Like, of course, the dry suit hose is a famous one, right? I've put it on, but I haven't tug tested and it's fallen off. Certainly O2 diluent, dry suit hose, and a few things that are really potentially will cause you a problem in the water, I think has to be on there. One question I wanted to ask you way back, and let's close with this one, is you talked earlier about the field of hyperbaric medicine research and how difficult it is to get funding because it's this niche area of diving. And it is, right? It's just this little small area, a small number of people participating. And then the other thing, of course, is that in order to get some meaningful data, especially around decompression, the NEDU studies, they were in fact bending divers. And I imagine, in fact, you said it ethically, that's a little bit difficult to get past those who approve these things as well. Where do you see dive research going? And in fact, where would you like to see it go?
Well, you could almost use the conversation we've had over the last hour and a half as a template for some of the things. There's been a number of questions you've asked where I've said, you don't have much data. I don't think there's any one particular theme that should dominate over all the others. I do think the human factors thing is a great opportunity for some research work, and we have a few plans in that regard. We've got a few plans. I mean, we have funding from the US Navy, which we're very lucky to have and very grateful for. And one of the things that I would like to say, since many people in the New Zealand diving community may hear this podcast, is we're deeply grateful for the support that we get. Many of the New Zealanders will know my PhD student Xavier and his wife Hannah, who is a postdoc with us, and they are constantly seeking participants in our various research projects. And I'll tell you, we almost never have any trouble because the divers are so willing. And
well, so I remember complaining to Xavier because he had a cutoff, I think, of 50 years old for one of his studies, or 55 or something. I was mortally offended that I couldn't go and participate. So
yeah, no, we generally get extremely good support, and we're really grateful for that. And we are answering some really good questions. Again, I won't articulate a list of them, but there've been some initiatives that have come out of our lab that have changed practice and the way things are taught to rebreather divers and that kind of stuff.
This was hyperoxia and
yeah, the hypoxia studies, the study where we looked at whether you can detect hypercapnia by doing a 5-minute pre-breathe and showed that doesn't work. Those kind of things. What we do try to do is identify questions of practical relevance to the community and answer them. And we're ongoing with that. It's a great question, but I don't think there's a particular theme. I do think, like big picture, it would be very nice to have a little bit more focus on where that sweet spot is for deep stops that we talked about. And I think that will gradually emerge. There's been a few other little research initiatives. Mark Powell is involved with the Jan Europe guys, and they've been doing a bit of stuff in that regard. And gradually we'll form a picture. But I don't think there's any one thing that I would say is, critically important. But participation and support of the research programs that we do have, that we're lucky enough to be able to do, is really important. And divers who are listening to this and then get asked to help out with some aspect of our research, we'd be really grateful if you do. And it's very helpful to those who are going to come in the years to come, that this is how we make progress. We do studies and we answer questions.
Awesome. And also to amplify what I said earlier, and also make it digestible for the dive community, which I think is so important in making the research digestible for divers. And so therefore we can incorporate it in our dive practice. So thank you to you and Xavier and Hannah and others who are involved in this, because I think it goes to make all of our diving better and safer, which is ultimately what we're looking to do.
Yeah, well, back to you on that one, Steve, too. Like you provide the opportunity for us to talk about it, like on these kind of things. And the people that organise meetings like TechFest in New Zealand and OzTech and Eurotech and Baltic Tech and Tech Dive USA, I mean, all those meetings are platforms where people like me can turn up and bang on about the stuff we do, but hopefully in an educational way. And, so there's that process of studying things and educating the diving public involves a lot of different steps, and you're providing one of them with these kind of podcasts. So good on you too.
Yeah, thank you. I appreciate it. Well, mate, it's been emotional. It's been great to catch up and see your smiling face again. And mate, I hope we catch up on a trip again soon. So the next Truck Lagoon one I'm still waiting for. So maybe next year there's a possibility for that. I don't know if you'll line up to be the dive physician on that one, but that would be amazing. And then I'm at Canterbury every month. So I'd love to take you in the machinery spaces.
Let's do that. Look, I'd really love to come up and dive Canterbury. I actually have a trip to Northland planned. I'll communicate with you offline about this, but no, I'd love to. I actually think it'd be super cool to do Canterbury with you. I think that would...
Let's make it happen, and we'll get some good film. There's some amazing things happening, which I'm not allowed to talk about in the boiler room at the moment, which is turned it into this completely silted out space that may or may not be habitated by a certain species at the moment. That's about as far as I'll go, but it's an amazing dive normally because it's crystal clear, and right now it's almost completely silted out, which makes it a bit dangerous, but at the same time, it's a brilliant dive in the machinery spaces. So yeah, love to do it with you. All right, mate. Well, thank you.
Good on you, Steve.
Cheers.
Thanks.
Cheers.
Hey, thanks again for joining me on this episode of Speaking Sidemount. It was brilliant to be able to share with you the second part of my conversation with Professor Simon Mitchell. I really enjoyed learning more about the impact of gas density and CO2 retention on our diving, and I also really enjoyed covering off on some of the misconceptions and dogma that exists around diving. And then lastly, our discussion on human factors and the impact on diving, and how we can use things like checklists to make our diving so much safer. Thanks again for joining me. Thank you to XDEEP and the patrons of Speaking Sidemount for your ongoing support. I'll look forward to catching you in the next episode.
You've been listening to Speaking Sidemount from www.sidemountpros.com. If you like the podcast, please subscribe and consider leaving us a 5-star review. If there's something you'd like us to cover on the show, then let us know via our Facebook page listed in the podcast notes. Thanks again, and we look forward to you joining us on our next episode of Speaking Sidemount.